So, yeah, we'll basically start with the liver today. There's, I sometimes I wonder if this. I conjured up the other two PowerPoints from the Marine textbook, and maybe I'll get back to those toward the end, depending on what we've covered with regard to the liver today. I mean, it's pretty straightforward. I am not that concerned here about the anatomy of it. Yes, it's the large. By definition, it's the largest organ. The skin is your largest gland. If you're curious about those things that people sometimes have an interest in, upper right quadrant, very easy to establish where its location is. Nothing unusual about that. Reddish brown in color. I mean, filled with blood. That's the reason why it gets that color. Tremendous amount of blood supply, and it's a big problem when livers are damaged in trauma. I mean, they bleed a lot. That's really a problem. And when liver blood is, yeah, when you start to see a lot of that, that's never a good sign. So and they're hard to fix internally. There's a lot of them. Thankfully, the liver is of all the organs you have, is you can make the argument it's the most highly regenerative one that we have. Okay, because really, the cells are almost identical and it's highly simplistic. In classical anatomy, okay, they go into this. Uh, One, if that is something that you covered in lab, great. I never even touch it. Basically, it's divided. They have a they even know it's not real. They call it the falciform ligament. Little bits of tissue that were parts of the peritoneum have sort of acted to divide the liver. The liver is basically identical. So they called it a ligament as if it was making a functional divide, like you'd have a big ligament, like a cruciate ligament in your knee. They call it the falciform ligament or the round ligament. It's little bits of the umbilical cord. Now we call it the umbilical ligament. Ugh. So, I mean, in classic anatomy, that's where that comes from. I could care less. Here's the idea: any piece of liver that you take, okay, reflects the entire liver. It is all identical. So the liver is got just an identical, millions of identical subunits. Okay, there are little hexagons called lobules that are all doing the same thing. And we want to see if a liver is not functioning properly, and it's done with some degree of frequency. They do what's called a liver biopsy. It doesn't matter where you take the biopsy. If it's messed up in the upper right portion, it's messed up in the lower left portion. It doesn't matter. Okay, so all of those lobules are identical, and they consist of effectively identical cells, as you'll see, and the illustration tells it better than I could tell it, around a central vein. Okay, you might remember from blood vessels, these are called sinusoidal capillaries. They're big gaps because the blood that's coming into the liver is laden, Laden, with all of the stuff that has been absorbed, sans the stuff that's going through the lymphatics, like fats and things like that. All of that is coming in, all that nutrient laden, particularly toxin laden, bacterial laden, virus laden stuff that you and I have ingested when we just had lunch. Okay, is basically making its way by way of a unique system called the hepatic portal system, as you can see there. And effectively, that vein drains, and that's the parlance we use. It drains to some extent the stomach, though not much should be coming from there, but the large and particularly the small intestine. Well, that goes from one capillary bed there, all those neat little villi capillaries, takes it, collects it into the hepatic portal vein, goes to the liver, and then the liver goes into another capillary bed made of these sinusoids. And because there's such large opening, basically all of that nutrient, potentially toxin, potentially stuff, laden blood gets processed by the liver. It gets detoxified. We start making proteins out of the amino acids. We make clotting factors. We make complement for inflammation. We make this. We make that. The liver is extraordinarily important. And interestingly, it's already heavily laden with fatty tissue. It's a very fatty organ to start with. And so it's a real worry when we're talking about people as we That was really the most telling thing when you used to look at people for their BMI, that basic metabolic index. The idea: are you overweight or are you over fat? What percentage of your body is fat? If you're in that 35 to 45% obese range based on fat content, you're really putting a significant burden on your liver. Significant. People have to, and unfortunately, our society today in this country, a lot of people are and still are. Okay? So, I mean, this is hello pot, this is kettle. You know, and for someone who didn't do a whole lot of that stuff, it behooves you to be at least cognizant and watchful of all that. So, what happens? It comes by one vein, goes to from one capillary bed to the hepatic portal vein to the liver, another capillary bed. It goes to, as you will see here, to a central vein. That central vein eventually leads to something called the hepatic vein, which leads to the inferior vena cava. So all of this gets processed. And you're going to see it's an interesting arrangement because you have two things flowing in and one thing flowing out. It's very odd. You don't see this almost anywhere else. So the blood flows, again, sinusoid central veins, then to the hepatic vein, then to the inferior vena cava. So it's in the meantime, it's making this magical chemical called bile that we need to be able to dissolve or absorb fats with its help. Plus, we're getting rid of that substantial waste product from red blood cells breaking down what was left of the heme unit. Remember, we talked about that. It made something called bilirubin. And the bilirubin eventually is the agent that we excrete both in urine and feces, and it gives that distinctive colors, so to speak, to both the urine and the feces, if you're curious. I don't get anything out of that. Here's all those false ligaments and round ligaments. And here's the gallbladder. And the gallbladder, again, non-essential tissue. Basically, as we'll see, and I'll talk about, the gallbladder is an overflow tank. The best analogy in the world, I think, for that is that where you put the antifreeze under the hood of your car. Okay, and before we had those things, and they're in the last 40 or 50 years. Okay, when your car, you open up the radiator and you checked it, and you added antifreeze directly to that. Then they developed this so you could have this overflow tank. When it needed more, it went in. When it had too much, it flowed out. That's basically what the gallbladder is. So we can do without the gallbladder. The gallbladder's job is to concentrate the bile and basically pump it in when it's necessary. But the liver can do that with the signals that come to it from that cholecystokinin. Cholecysto designates anatomically this bad boy, okay, the gallbladder. And so you can see here, this is where we have this, what we call the triad developing. You can see the inferior vena cava is in a different location. Here you have the hepatic portal vein, the hepatic artery, and the bile ducts. The bile ducts are bringing the bile out, either from the liver or from their temporary storage facility in the gallbladder, okay? And then blood to be processed is flowing in by the hepatic portal vein, and it's a very busy area. It takes a lot of energy to do all this stuff, so it needs a lot of arterial flow, hence the hepatic artery. Voila. That is an example. And I'll show you that I like the diagram and the other one a little bit better. This is the sort of the schematic. This is the actual look of what liver looks like. So you can see that they are roughly hexagonal structures in each of the 6 points of the hexagon. You have this grouping. You have a branch of the hepatic portal vein, you have a branch of the hepatic artery, and you have a bile duct. So as the blood flows in, it comes into intimate contact with these banks and banks of cells, hepatocytes. They're all identical. And they are doing all that stuff that the liver does, all the processing. It's taking the nasty nitrogen products we're going to talk about when we talk about the kidney. Okay, when you and I digest all the proteins, and we ingest a bunch of them in this country, all those proteins get broken down to amino acids. In order to use them, we have to take off the amino group. Sometimes we'll use them directly, but a lot of times we'll take off the amino group and we'll staple it back on if we're going to make proteins. That's the liver. What happens to all the ones that we don't make more proteins with or utilize amino acids, we end up by removing that amino group, it becomes ammonia. Ammonia is a horrible toxin. Okay? So what does the liver do? It takes carbon dioxide, mixes it with the ammonia, and you get something, okay, called urea. Urea is about 100 times less toxic than ammonia. So we're cleverly using a waste product in our bloodstream. Carbon dioxide doesn't it do a lot of things. In the meantime, it forms this chemical urea, which is easier to excrete. What makes it less toxic is the liver, and this is what the liver does a lot with toxins. It makes them more water soluble, so the kidney can get rid of them. It's a good thing. Say hi to your liver every day. How are you doing? I'm doing well today. Promise your liver you're not going to have any pâté de foie gras. See, in our day and age, we ate a lot of liver because it was cheap. That was like you couldn't afford steak, so you ate liver. That's why people got used to eating it covered in mushrooms and onions and bacon and all that. Not in our house, but mushrooms and onions and things like that. And in our house, large quantities of ketchup to kill the taste. Mom, why are we always having it? Because we're too poor to afford steak. No liver eaters here. What a memory. In New Jersey, there was a wonderful diner. New Jersey is the land of diners. This diner was up. I'm surprised they didn't mention The Sopranos. It was up in right where The Sopranos were depicted. Okay, called the Claremont Diner. And they had, food you could cry on. So good. And they had this wonderful dish with chicken livers, mushrooms, onions, and bacon. And a very close friend of mine, we used to go there, and she would always order that. Whenever we went there for dinner, and they had wonderful desserts. And every time, you know how you're going with somebody, it was a date, but we were more like buddies as opposed to boyfriend. And I say, boy, can I have a bite of this? She goes, no. How's that? I'm eating every single piece. You can't have it. That's that girl got a PhD in chemistry and unfortunately succumbed before she was 50 years old to ovarian cancer. So it kind of looks like this. This is the trio that comes in. The artery, obviously, is going to give up its oxygen and become venous blood. The hepatic portal vein, all that blood's going to get processed and picked up. And the bile is being produced not just as a waste product, but an important waste product in the sense that it has enzymes in it that facilitate yours and my ability to digest fats, et cetera, et cetera. And that's the flow. So it's really very accurately displayed there. This is what they look like. So in a liver biopsy, if you see this becoming irregular, what will happen is scar tissue will form and it will distort dramatically, distort those hexagonal lobules. And that's when we can tell if somebody's got hepatitis. Or worse, if somebody's getting cirrhosis. Because you'll see that all over. The cells will die, they'll be replaced by fat, then scar tissue, and that's very significant. Cirrhosis can happen with any kind of hepatitis, but obviously the one we hear the most about is alcoholic hepatitis. That's there. If you're wondering how much you have to drink you have to be a pretty darn serious drinker. Probably to really get to the point where you have to really be at risk of hepatitis for about 10 years, drinking every day at least a 6-pack, at least a bottle of wine, or at least a bottle of booze. To basically that consumption daily for 10 years. That's a lot of serious drinking. And unfortunately, there's a lot of people who do. Just saying. So what does the liver do? It makes glycogen. The only way we can store carbohydrates, glycogen in the liver, an emergency supply, skeletal muscles. It can, when we need more glucose, this is what glucagon does. It's glycogenolytic, meaning it'll break that down into glucose. This is something called gluconeogenesis. These are not major things that you need to know, but it's giving you a look at the list it's got to do. I don't have that much to do. And believe me, I have a lot to do when I get home. Got to do this, do this, do that. I don't. I'm going to ask the liver to add that to its list. Okay. Would you check? Certainly. Non-carbs to glucose is called gluconeogenesis. Breaks down fatty acids, synthesizes lipoproteins. It's how we transport fats in the bloodstream. Phospholipids, all about membranes. Okay. Makes cholesterol. We need that everywhere. Okay. Excess carbs into proteins. And this is the problem with diet, into fats. If you don't use it within the first minute, all that wonderful ATP, your body basically says, okay, overload, store it. And the only way we can store, we don't have limited carbohydrate storage. That's just limited glycogen, then it has to go to be fat. That's there. Deaminates, what I was telling you about with amino acids, makes the urea, makes plasma proteins, albumin, the globulins, the fibrinogen, amino acids are switched, stores all of these good things. If your spleen's gone for whatever reason or poorly functional, it can take over. Okay, and big toxins, alcohol, drugs, blood reservoir, secretes bile, da-da. Talk about vital. Okay? And the beauty is now we've learned that we can actually do live liver transplants. I don't know what the criteria is for all of those things, but there is some limited capability now with regard to that. Okay, so while all of those types of things that it does, general functions, you can read through that. Required to maintain life. Regeneration, if 25 to 30% of it is healthy, that's really good. Cancer spreads to the liver. First time I saw an autopsy, might have been the only time I saw a complete autopsy. Unfortunately, it was a homeless individual. We had a lot in that part of, we went to school in that part of Philadelphia. And very close to where Liberty Bell is, the hospital's down there. And we saw the whole thing. The lungs were all damaged, and we said, and that was really the cause of death. It came from chemotherapy. We saw the liver was filled with tumors, dots and dots. The liver, it was almost like you embedded something in there. Let's say you took, embedded pieces of something all throughout the liver. And said this gentleman had severe liver cancer, undoubtedly an alcoholic. They started to treat him with chemotherapy. The chemotherapy eventually did his lung in, but the underlying, but the lifespan was shortened just the same. So regeneration can occur. There is a shortage of donor livers for transplant. This is very, very true. Yes.
How do livers handle extreme medications like?
Not well. I mean, that's why you have schedules. Chemotherapy. You're having to look at how long it's going to take them. What they would do is you would give chemo, and at the same time, then you would continuously monitor white blood cells. If the white blood cell numbers were going down, then you realize you had to wait for the liver to detoxify it, for the white count to raise up so you could do it again. Some agents are different than others. Some it could be every day type of therapy, some every week type of therapy. So it's really based on the comparatively close limited capability. That'd be the way. I mean, I can't explain to you any better than that. I'm thankful I've not had to ever, had to be up close and personal with that either for myself or family. Bladder cancer is a little bit different. They just put the chemotherapy agent in there and basically say, stay in there. You're not getting it from the outside. And that saves you a lot of the problems associated with it. When you give something systemically, chemotherapy is a poison. It's going to poison tissues. The liver only has a limited capability. Maybe that's the best way to talk about it. These are something that are interesting. These so-called extracorporeal, means outside the body. Okay, assistive devices. I'm unfamiliar with those too. I think of it sort of like like we have dialysis for the kidney. This would be the same a la that same kind of function, having something, a machine that can do the work of the liver, although limited. Okay, so as you can see, it's a combination, which dialysis is not. Dialysis is just an elaborate series of filters that can do the filtration, like the kidney. This is when you're using, bio artificial. Very interesting. Yeah, that type of thing. So toxins are removed, liver secretions are added, and the plasma is returned to the patient. So I mean, this is all stuff that's so new. And again, for many of you, depending on if you're going into a medical field, it depends what field you're going into and where you're going to see this stuff. I mean, if you're practicing rural medicine someplace, you're not going to see that. If you're going to be on the firing lines here, like at Presby or a big city hospital, trauma center, all that sort of stuff, it's fascinating. Fascinating to see I probably wouldn't recognize half the stuff anymore. Because the hospitals that I worked at were pretty much nuts and bolts hospitals. The branch of St. Francis that I worked at is now where the Penguins are try to skate. They got one guy who skates, and everybody else skates. For like the umpteenth year, he's been voted. Sidney Crosby has still been voted by the other players the best all-around player. He's not a kid. Here's Biol. What it makes. This is a use of cholesterol, one of the many, like being in membranes, and we recycle it. 95% of it is recycled, the bile salts. And I'm sure they'll cover it here. You're going to see this particular pathway. So it helps to break down fats, emulsifying, basically separating them. Only bile components that have a digestive function, and that's the emulsification. The pigments, these they're getting rid of. Okay, so all of that, water, additional cholesterol, electrolytes, and this is the problem. If anything blocks it, whether it's a blockage in the gallbladder, whether it's a blockage from problems with production vis-a-vis the liver is damaged or diseased or in the middle of hepatitis or someone's undergoing chemotherapy, all of those kinds of things. Anything that doesn't allow the liver to do its job, it's a plumbing problem. It backs up into your bloodstream and it manifests itself as jaundice. First place to look, the whites of the eye that are there, looking at mucous membranes, they get sort of a yellowish cast. Wait till you see it. And that's the beauty of medicine if you're going into a clinical field. Once you see something, it sticks in there. I remember seeing my first case of acute gout. Never forget it again. Bang, that's just what it looks like. First time I saw somebody with jaundice, bang, you know exactly what it looks like. Hitting edema, bang, you know exactly what it looks like. Experience is a really great teacher. That's there. So all of these things, variety of types of hepatitis, varying in severity. Some are asymptomatic. They're asymptomatic carriers. Unfortunately, if you're in my microsection, we've talked about this. Unfortunately, there are people who carry the problem, but they don't have the problem. Okay? And they progress to all of these things: upper right quadrant pain, dark urine, changes in the way the feces look, jaundice, all of those types of things. They're all tells. And everybody, it can happen. We don't make the presumption that these are people who got it because of their, IV drug users or HIV based or, alcohol based. Maybe I told you. I have a couple of first cousins who were very close. All the families were baby boomers. We had kids that were all the same age. So I have two guy cousin and a gal cousin and another guy cousin who have less contact with for the most part over the years. We're all about the same age. Lovely girl. She married a guy. They had two boys together, and when she was pregnant, she did not know it was a third boy. But going into the marriage, they knew he had, as a kid, something had damaged his liver. I don't know whether it was a medical, whether it was something he had come in, like some type of poison he had come in contact with a kid. They knew it. I mean, when Dr. Starzl came here to Pittsburgh with liver transplants, she got on the phone. I got a phone call. I was up in practice. If I knew anything about the Starzl Institute, he was on the list. So, he had gotten on the transplant list. He was 28 years old. She's got 2 boys and pregnant with a third. And I made some calls. I found out what was going on. I gave her a call back. I was more than willing to go because my ex lived in the area. So she knew people, places where she could stay, all this stuff. I finally get a call back. That sad call. And it was on. They were about to move here. Fine. Unfortunately, succumbed to his liver disease. It came, whatever that is, died. How's that? Yeah. But very, very difficult. Good person. Very street smart girl. And it turned out she her second her she remarried a wonderful guy. We just took care of those kids for all of them. They're married still. They're probably married 40 years. I'm trying to remember when this was. More than 40 years now. She found a guy who was just was willing to take those kids on his own. A lot of good people in this world. So several types of viruses. We've learned about that in micro. Maybe you learned about it in your micro class that are there. Bloodborne very frequently. The hepatitis A is the oddball. That's fecal to oral. So, they're not necessarily all. That was a very famous outbreak here. I talked about in my class with Chi-Chi's. That was hepatitis A, et cetera, et cetera. So we don't need to go into this there. And as you can see, there's other forms. The E, it's my understanding, I think A and D are both oral, and don't quote me. The only ones I know about are A, B, and C. But E may or may not. I do not know whether that is oral, fecal to oral acquired, or blood or body fluids. And obviously, it's viral, and antibiotics aren't going to work. The gallbladder, undersurface, okay. And eventually it forms part of this famous structure, the common bile duct, which is where the secretions from the pancreas come in, as you already know. All it does is stores. The trouble is it's got lots of little folds for surface area. And some people, when they concentrate it, it gets quite hard and it forms stones. They're more common than you think. They are more, in general, they are more common in women than in men. They are more common in younger women between the ages of 20 and 40. They are more common in women who are fairly complected as opposed to darkly complected. And very often women who are fertile, because what we do is we see this preponderance of hormones during pregnancy in certain individuals that will often trigger the onset of gallstones. Whether I told you or not, it's worth telling again. Both of my grandchildren, the ones whose names you used to log on to tests, Anderson and Malin, okay, they are products of IVF, if you did not know, and I probably have told you. So when Malin was born, she's the elder one. My daughter-in-law, shortly thereafter had to have her gallbladder out because all the fertility things that you use for IVF are all prednisone, estrogen, progesterone-based agents, very, very similar. Those are the fertility agents that they utilize during the process of IVF, of in vitro fertilization, if you didn't know. So she had to have hers out. So all of those are part of it. First thing they told us in emergency room, we have typically with anybody who's and being overweight is part of it. So if you had an overweight, particularly a female, but also a male with upper right quadrant plane that came in and you listen to the story after they ate something, what did they eat? It would seem like a high fatty oriented meal, or that struck as being part of their diet. Gallbladder to improve in other words. It's like ruling out appendicitis. Lower right quadrant pain. Upper right quadrant pain, you start thinking of gallbladder. It doesn't exclude appendicitis. So all of those things that are there can enlarge. Those are what gallstones are. Excess bile concentration, etc., etc. Lots of different things. Cholecystokinin triggers it, release. Hello, stones. And the stones can be anywhere. They can move and they can clog the common bile duct. They can move that and they can cause backflow of fluid into the pancreas. And the pancreas will develop like a big fluid accumulation. It's called a pseudocyst. Pseudo for false. It's not really a cyst. It's just fluid that can't get out of there, and it makes the pancreas enlarge, and it can't do its job. Now you're in big trouble. I was going to use a different expression with some creative use of the F word, but I chose not to in this particular. I hope because Allie's here. If she wasn't here, we'd be swearing like a sailor. She's got delicate. Not Brooke, however. And this is the interesting part about this circulation. We basically reabsorb a lot of this stuff that's there. The bile is reabsorbed and reprocessed. We don't have to go into all that is. It emulsifies, aids lipase, which is the agent that helps it help absorb the famous 4 letters ADE, however you want to remember it. Fat soluble vitamins, ADEK. You had to have this in nutrition. 95% are recycled. Those were the old original quote unquote cholesterol medicines for high people with cholesterol. Too many side effects because they agitated your liver. So, upper right quadrant, noisy, anything. We used to do. Well, I would be the one who was called up from the. Because I was a good IV sticker back in the day to start like the drug addicts to do these things to do. It's called an IVC. Okay. Intravenous cholecystograms. So you had to introduce the contrast material intravenously. So I'd be running up. They call me up from wherever I was on the floor in the OR. Run over. You got to start an IV for this patient. So I had talent back in the day. So all of these things can happen. So there's lots of places. These days, you can remove the gallbladder. You can do it endoscopically. You can remove the gallbladder. You can remove stones. They do a lot of what is called lithotripsy. Do you know what that litho means stones. Tripsy means to shatter them. How they shatter the stones? Ultrasound. High frequency sound waves and use them for kidney stones as well. People will sit basically in a modified kind of a bathtub with sedation, and basically because sound travels much better through water, and boom, they'll put a device in there and try it because it'll pulverize the stones at the right frequency of ultrasound. They'll become powdery and they'll be easy to excrete, whether they're coming from the kidney or they're going to pass more easily and get out of the gallbladder. Lithotripsy, important. All the different things that are there. The gastrin is from the stomach, and you can go over that. Okay. Cholecystokinin, that small intestine, secretin, those are the big ones to remember, which brings us down the road. And I did have those other things to look at. I guess since I conjured them up, I might as well take a look. And I don't know if the illustrations are any better for you as I scroll. That's a typical lobule. You can see the vast amount of cells. The liver is enormous. This is a tiny amount of the liver. Just one tiny micrograph of it. So you can imagine how much it's doing. Everything is going toward that central vein. And here is a really good illustration to show you you can see how all these plates, and it just sifts its way through. Not unlike when we talked about lymph, going through lymph nodes and all the sifting kind of percolating its way through. You have a lot of inputs going to a central output. So it takes its own sweet time going through there so you can get sort of maximal processing done, if you want to think of it that way. So 900 milliliters of bile per day, it's about a liter. All the different things, and every book will have all of this. This is that reabsorption thing. So again, you don't have to know it's similar illustrations that are there. And it's a good word for the gallbladder. They talk about honeycomb folds that allow it to expand. Unfortunately, those are areas where things can get entrapped as well. Biliary calculi. Here's the lithotripsy, lasers, and operations too. Yes.
That's similar to how when you have like bumps in your blood vessels, it causes like turbulence, and that's how you clot. Is that a similar concept here?
But to form stones?
Yeah.
No, I don't think so. That clot, I mean, turbulence is about clots. I think the stones is more chemistry related. I think it has to do with what you're ingesting and how it forms it. For instance, when you get kidney stones, a lot of them relate to calcium. Sometimes they need a core. The core can be bacteria or blood or excessive amounts of calcium, where here in the gallbladder, it's more about what you're consuming. That it makes, as it's starting to concentrate it in the gallbladder, the nature of what it's having to concentrate firms it up. Does that make sense? Let's show a little, and now we're getting to really the most important part, because after this, there's not a lot of function, to be very honest with you. The large intestine doesn't do a lot. The large intestine has got some interesting anatomy, and you have the appendix coming off it, and it's got a special name for that area called the cecum. I'm sure you did this in lab. Yes, appendix, cecum, haustrum, tinea coli, epiploic appendages, right? See, I read the book. I'm supposed to know that. But other than that, it's non-essential. You don't need a colon. Okay? So it's nice to have. I'm not recommending you lose yours. You donate your spare colon here. No, thank you. You don't see a lot of that going around. It's like if you have two belly buttons, you wouldn't want to put one in the naval reserve. Naval. See, wasn't that clever? See, one smiled. Yeah, not Grace, because she's Army. She didn't want to hear about the Navy. You're no fun on Army Navy games. Sorry. Just wait till you're at the Pentagon. I'll have an admiral there to give you a hard time. You'll be looking forward to it. I'll have him look you up. You don't want a 2-star being mad at you. Small intestine. We talked about it. All the way from the pyloric sphincter, where it starts from the duodenum or duodenum, all the way out, most of the abdominal cavity, chyme from all of these areas. And this is where we complete digestion. It's mostly chemical. The mechanical act is more about just moving it, segmentation back and forth, peristalsis pushing it along, and effectively all of the absorption. And the vast majority of this occurs within about the first third. By the time it goes through the duodenum and basically is through the jejunum, the next part of it, done. What's left over goes to the large intestine. Large intestine is about getting rid of the stuff that's left over and making sure it's moist enough and of the consistency enough to pass without causing us a lot of distress. Not too fast, not too slow, without getting graphic. So, duodenum, this is the part, the stable point. Why? It's the critical piece because of the common bile duct. The jejunum, very, very active, and it's really, this is where the vast majority of chemical digestion and absorption takes place. At this point, the ileum, you're going to have a lot. What's left over are there problems? Lymph nodes are there just for that purpose. Did we miss something that could be a source of infection? Bacteria, a virus, an invader. So, and again, they're all suspended in the mesentery because there's a lot going on. They need a lot of blood supply going in. They're transporting a lot of the stuff in and transporting it out. And you see anatomically, they have the omentum being the singular. And effectively what that is, that's fatty laden tissue. That's again, mesentery. And it's almost like it's hanging down from here and covers the small and large intestine like an apron. And so in surgery, you're very, very careful with that to make sure You move that out of the way. You don't want to cut through it because that's blood supply and things like that. And you have to lay it back in because again, what you don't with whenever somebody has to go in there and do something, whether it's an appendix, which is relatively straightforward, or a gallbladder, or a major surgery like I had, you have that basically you want to drape all that wonderful fatty tissue so it doesn't adhere to the front wall, the peritoneum. That's an adhesion. Anything that is designed to move over one another freely. If it doesn't do that, it's a problem. That's surgeons worry about that more than anything else when they do general surgery, abdominal surgery, adhesions, scar tissue, nasty stuff. Then they have to go back in, and anytime you go back in, you're creating, guess what? More scar tissue. Ain't fun. That's why that guy took 8 hours twice on me. Slow, meticulous surgery. Every little step. God bless. So you can see, and here's the transition. So you have duodenum, 10 inches, jejunum, maybe 8 feet. The rest is ileum. It looks pretty much the same. It's just not. Interior wise, it's very similar. And here you can see what's called the ileocecal area. It's a sphincter that's there where it narrows. And look at that bad boy jutting off the cecum, the first one of those haustrum. There it is, the appendix, formerly known as the vermiform, vermiform, which means it looks like a wine. Say a mile neighborhood. Worm-like. Wine. Voila, these are all there's a really good, that's the greater omentum. Between the stomach and the liver, there's something called the lesser omentum. But again, all of these, it shows you how everything is draped in these linings so it can easily move over one another other than when it's tacked to the back wall. When all those mesenteries have been resorbed sort of into the back wall of the abdominal pelvic cavity, that's called retroperitoneal. There aren't a whole lot of those. Duodenum would be one, pancreas to a certain extent, your kidneys, as you'll see, your bladder. Okay, all those systems are on the back wall. They get out of the way. You might have noted when you did like whatever dissection, a rat, whatever, if you felt around on the back wall, once you move the alimentary canal out of the way, you find 2 little lumps. Those are the kidneys. Kidneys. Tiny projections of the mucosa. This is the beauty of this. It's elegantly designed for surface area. We looked a little bit, look at this. You're going to look at villi, fingers, tremendous amount of surface area. Each villus, singular, simple columnar, blood vessels, and each one of those capillaries wraps around a lymphatic capillary called the lacteal, an important name to remember. Certainly there's nerve fibers, and it's surrounded, that finger, on this side, that side, forward, back, all over, surrounded by simple columnar cells with microvilli, more surface area. And then if you imagine these little, if this is like a little crypt. So here's my finger, and going down sort of below the level, and these little indentations it's called a crypt. The fancy name was crypts of Leverkuhn. They're really intestinal glands. They are the most highly reproductive area in the alimentary canal. Those cells are being replaced faster than anywhere else in your body. How do we know that? That is the area that is most rapidly affected by chemotherapy and radiation therapy. That's why, what do people get when they have radiation therapy and chemotherapy faster than anything else? Diarrhea, nausea, vomiting. Right there, baby. Like every 2 to 3 days, they're all being replaced. Billions with a B. Every day. So, and the way it passes, plica circularis are circular folds. So when food passes through there or liquid passes through there, it's not shooting down a tube. It's not your garden hose where you turn it on. Okay? What happens is it goes around like this, spiraling all the way down. And it's designed to take all of these are anatomical, I don't know if adaptations, anatomical structures that increase effectively the surface area. This area. Here's Villus, here's a little crypt. Here you can see what it kind of looks like here when they're looking at these little crypt-like areas. And again, this is where they produce those all the water, the bicarbonate, the secretin, the whole cholecystokinin, all those wonderful enzymes that might be necessary. And this is where along here they have what are called brush border enzymes. The little enzymes that make, when you have lactose, make you not, if you have lactase, one of the enzymes, it'll break it down into glucose and galactose. It will help you absorb amino acids. So when you have digestive problems, a lot of times you're missing these. Because look, enzymes are proteins. We make them because of genetics. Here are the microvilli. You can see them here. It's a good micrograph. These are busy cells. Busy cells are busy because a lot's going on. They're absorbing things, they're processing, and they're carrying them through. And you can see it here. Here you can see these circular folds as it spins around. It's really very interesting. We'll stop it here. We'll pick up some of the chemistry behind it next time. Again, next time won't be until Monday. So for many of you, I won't see you until then. Have a wonderful mini holiday break. For those of you in lab, see you soon. Hasta mañana, baby.
Question.
Sure.
When people are often found to